Good. Um, Lovely. So let's get started. So good evening, everyone, and welcome to the fourth webinar of the August Seminal 6 series. Every week we've been looking at 6 influential studies in a specific field, and tonight's topic is evidence-based practice in acute pancreatitis. I'm delighted to welcome Professor Sanjay Pandanaboyana, a consultant HPB and transplant surgeon at the Freeman Hospital in Newcastle. His academic and clinical practice focuses on pancreatic cancer and acute pancreatitis, and he's published over 200 papers in these fields. In pancreatitis specifically, his work includes international multi-center studies, including the PAIN-AP study and the COVID Pan Collaborative. Now, in addition to his busy clinical and academic commitments, Professor Pandanaboyana sits on the committee of several organizations where he advises on research and best practice. This includes the Pancreas Clinical Research Group, the Great Britain and Ireland Pancreatic Society, and EHPBA. He also chairs the Surgical Specialty Board in General Surgery for the Edinburgh Royal College of Surgeons. I'm sure we're all looking forward to hearing of the evidence that really underpins how we manage acute pancreatitis, a condition we all see so often in our practice. And can I encourage everyone to share your questions in the Q&A throughout the presentation, and we'll have time at the end of the webinar to go through these. So without further ado, I'll give the floor to Professor Sanjay Pandanaboyana.
Thank you, Alex. Thank you for the kind introduction. And again, thanks to Aujis for asking me to give this talk on acute pancreatitis evidence directing practice. So over the last 10 years, there have been quite a few randomized controlled trials in this area, which have increased our understanding of management, at least early management of acute pancreatitis. So I thought I'd focus on some of these newer trials published in the last 10 years or so. Although I was asked to talk about 6 seminal papers, I've actually broken it down into various aspects of early management, and some of those aspects of early management would involve more than one manuscript. So please bear with me so we can look at the evidence, and hopefully the evidence will also change practice going forward. We all know the incidence of acute pancreatitis is rising. A couple of good systematic reviews, including one published by our group. A systematic review by an American group a couple of years ago has shown the global incidence of acute pancreatitis is rising by about 2 to 3% a year. And when we looked at the data in the UK, because there wasn't any data published from England, at least in the last 10 years, when we looked at the HES data, the UK incidence was very similar. It's going up by around 2.6% a year, which comes to around 23,000 cases a year, which is a huge number of patients presenting with acute pancreatitis. And then we also looked at the incidence of acute pancreatitis in England, and I live in the northeast of England in Newcastle, and unfortunately Newcastle has the highest incidence of acute pancreatitis in the UK, and there seems to be a trend here where as you go up from south to north, the incidence seems to be increasing, with the highest incidence in the northeast and the northwest, and London having the lowest incidence of acute pancreatitis. And quite a bit of that might be also related to social deprivation. And we know social deprivation increases as we go up north, and that could be one of the reasons why the incidence is much higher as we go up north in England. And the impact of incidence is not just the number of cases. We can also look at the impact of the incidence with the cost it might cost the NHS. For instance, when we looked at the HES data and when we put together some costs based on the NICE costings for hospital admissions, we calculated that the cost of admission for acute pancreatitis per episode is around 10,000 pounds. But once you add the quality of life years lost per episode, it comes to 117,000 pounds per case. And when you look at the national incidence of 25,000 cases a year, that's a financial burden of almost $500 million for the NHS just for managing acute pancreatitis. So there is a huge, not just health burden, but also an economic burden from acute pancreatitis. The important thing to realize about acute pancreatitis before we go into the trials is how the mortality occurs in acute pancreatitis. And this is a review article we wrote for BJS last year. As you can see, there are 2 peaks in mortality in acute pancreatitis. The early deaths are from the severe systemic inflammatory response and multi-organ dysfunction and multi-organ failure. And most of these deaths appear within the first 1 to 2 weeks after admission. And unfortunately, there isn't anything we can do at this point of time to modulate the disease in the early phase. perhaps the RAPID-I trial being done in Liverpool might provide some answers on infliximab in the early stage, and the trial is still ongoing. And the late deaths in acute pancreatitis then tend to happen in the third to fourth week when you get infected pancreatic necrosis and you get the second peak of mortality. So you tend to see this bimodal pattern of mortality in acute pancreatitis. Even 10, 15 years ago, both these peaks were very similar, but now with improved endoscopic management of necrotizing pancreatitis, the second peak is much lower in terms of mortality risk, but still quite a high mortality even in the third to fourth week. So what we do, the interventions we undertake is predominantly reduce mortality. And these are the 6 topics I'm going to talk about where we have evidence in the last 10 years. And this is where these interventions predominantly act on. We want to reduce the early deaths, and that's by better fluid management, better pain management, which can reduce respiratory failure, and also risk modulation, where we're trying to reduce the risk of progression from mild to severe pancreatitis. And for the late deaths, again, the predominant intervention would be early intervention with endoscopic necrosectomy. So we can talk about that in the next few slides, and also what is the role of antibiotics. And finally, although there is quite a bit of emphasis on early management, there is some good data, at least from the Hungarian pancreatitis study group, where they've shown there is ongoing mortality post-discharge. So the story of pancreatitis doesn't finish when the patient gets discharged from the hospital, but it's also important to see what happens post-discharge in the long term. So first topic is the fluid management. I think most of you should be aware of the waterfall trial, which Enrique de Madariaga did in Spain and from Alicante. The premise for the trial is when you get acute pancreatitis, there is edema in the pancreas, and also these patients present with organ failure, especially those with severe pancreatitis, and reduced blood flow to the pancreas, resulting in ischemic changes in the pancreas and reduced perfusion in the pancreas, which can then result in necrotizing pancreatitis. And the idea with the fluid resuscitation, whether it's aggressive or moderately aggressive, is to reduce that progression from edematous pancreatitis to ischemic pancreatitis to prevent development of necrotizing pancreatitis. So the waterfall trial randomized patients to aggressive fluid management versus moderate fluid resuscitation. At the moment in the NHS, we've done moderate fluid resuscitation, but we don't know whether we should be aggressively resuscitating these patients to improve the perfusion to the pancreas. So that's what the trial compared. So in the aggressive group, patients received a bolus of 20 ml per kilogram, while in the moderate fluid resuscitation, they received 10 ml per kilogram. And then following that, patient had ongoing infusion of predominantly Hartmann's if they had ongoing hypertension based on the goal-directed therapy checkpoints. So this was the comparisons, aggressive fluid resuscitation versus moderate fluid resuscitation. The primary outcome measure was development of moderately severe or severe pancreatitis, because that is what we're trying to reduce, is progression from mild to severe pancreatitis. As you can see from the result, 122 patients were randomized in each group almost, and there was no difference in progression from mild to moderate to severe pancreatitis in either group. So the fluid resuscitation type did not change the progression of severity of pancreatitis. What they did find with the aggressive fluid resuscitation was the fluid overload was much higher. The patients had much higher symptoms of fluid overload. So based on this trial, they've concluded that although aggressive fluid resuscitation does not improve, have got comparable outcomes in terms of severity of pancreatitis, but it does increase fluid overload and signs of fluid overload. So based on these findings, the trial was terminated after the first interim analysis. The original intention was to recruit 400 patients in the trial, but after 250 patients, the trial was stopped because of safety concerns in the aggressive fluid group. So we have definitive answer from this trial that aggressive fluid resuscitation is not ideal or good in patients with pancreatitis because there is risk of fluid overload. There are some limitations. First is the trial was never really completed, so we don't really know if aggressive fluid resuscitation, although it can include fluid overload, does it reduce the severity of pancreatitis? So the primary endpoint was never fully explored. It was an open label trial. It's difficult to undertake a trial where you don't know which patients fall into which group, because you want to treat patients accordingly in the aggressive fluid resuscitation group as well, because if they got fluid overload, you need to give them diuretics and all that. So it was an open label trial more from a safety perspective. And also excluded patients with high risk of volume overload, patients with underlying cardiac disease or mild renal failure. These patients were excluded, so it cannot be translated to every patient who walks into the hospital, which we normally see. But at least we know for sure now aggressive fluid resuscitation is not ideal in patients with pancreatitis, and we should stick to goal-directed therapy with non-aggressive fluid management. Other burning question always is, when a patient comes into the hospital, should we be giving them ringalactate or normal saline? So that the Waterland trial, which is just completed now. Again, this is Enrique's trial. It's completed recruitment. He's recruited 700 patients into this trial, and the results should be published soon. But he presented the early data at UEG week about a month ago in Berlin. And again, there doesn't appear to be any difference between normal saline and ringalactate in terms of outcomes or reduction in severity in acute pancreatitis. So there shouldn't be any preference with one fluid type over the other, and which is an interesting point as well, because when you go to most third world countries, especially in sub-Saharan Africa, they may not have access to ringalactate solution, and they might just have access to normal saline. So it's good to know that you can use either of these solutions for resuscitating patients with acute pancreatitis. What about risk modulation? Because this is an area where we have a big challenge, because once the patient comes with acute pancreatitis, all we're doing at the moment is providing supportive care to ensure they don't develop severe pancreatitis, but we're not really modulating the disease in any way. We're not giving any drugs to modulate the disease. But there have been a couple of interesting trials from China. This is the first trial by the same group where they looked at COX-2 inhibitors. You must have all come across COX-2 inhibitors at some point, celecoxib and parecoxib. In this trial, they randomized patients to receiving standard of care, which is conventional management of acute pancreatitis, compared to conventional management with COX-2 inhibitors. So what the primary endpoint again was development of severe acute pancreatitis, as well as pain scores between the two groups. Definitely in the COX-2 group, the pain scores were much better. And also the development of severe acute pancreatitis was much lower in the COX-2 group after randomization. So they concluded sequential administration of parecoxib and celecoxib in patients with predicted severe pancreatitis could result in half a reduction of severe acute pancreatitis occurrence. So the reason they used parecoxib at the start is because it can be given intravenously, especially in the first 2 to 3 days. If the patient's not able to take oral COX-2 inhibitors, you have an option of giving intravenous parecoxib and then moving to celecoxib. But they felt the trial was underpowered, so they've done a further trial, which was published in Gut earlier this year, where they've used parecoxib followed by imricoxib, a slightly different COX-2 inhibitor, but more or less the same way of efficacy, where they randomized 392 patients, of which 348 were enrolled, with 174 in the per protocol population and 169 in the per protocol population. And after randomization, they didn't see any difference. They saw a big difference in the organ failure and persistent organ failure between the two groups. As you can see in this Kaplan-Meier curves, the curves diverge quite early on in the phase of acute pancreatitis within the first 5 days. So there's a big difference in terms of development of organ failure between the two groups. So based on this data, they've also showed reduction in the hospital stay when you use COX-2 inhibitors, reduction in severity of pancreatitis, and also reduction in mortality, which are all statistically significant. So they concluded both giving parecoxib followed by imricoxib can reduce the severity of occurrence of acute pancreatitis and also local complications, predominantly by reducing the systemic inflammatory response, which can then result in reduction in morbidity in acute pancreatitis. So there are some limitations. Patients with predicted severe pancreatitis was chosen by Apache score and modified Marshall score. And we know the severity of these scores in predicting severe pancreatitis is less than 80%. So although you predict at the time of admission using these scores, not all of them would develop severe pancreatitis. So some of the patients would have still had mild pancreatitis when they started the treatment. And quite a few patients were enrolled after onset of symptoms. That means the SIRS has already started, and once the progression of SIRS happens, it might be just a bit too late to start the celecoxib and parecoxib. It's always difficult to recruit patients into early phase pancreatitis trials because patients don't often present early on. They might stay at home for 24 to 48 hours before they come into the hospital. That means you miss the window of opportunity to treat them accordingly in the first 48 hours by recruiting them into the randomized control trial. Another challenge with COX-2 inhibitors is not all healthcare settings have access to these drugs. Um, what about pain management? And in the UK, the pain management is predominantly based on use of opioids, but pain can have a prognostic significance in predicting severity of pancreatitis when the patients get admitted into the hospital. Two good trials, both of them are quite small trials. This is a trial comparing opioids versus NSAIDs from India, where they used pentagocin, which is a kappa opioid agonist. Pentagocin is not routinely used in the NHS setting for early pain management. However, it's available in India to use, so they've compared pentagocin with diclofenac. The problem with this trial is pentagocin is a very strong opioid, and then you're comparing a very strong opioid with a weak analgesic like diclofenac. And the results were obvious that you get better pain relief with pentagocin compared to diclofenac. The pain scores are better. The need for rescue analgesic was better in pentagocin versus diclofenac. But the important aspect was there were no adverse events. So if you're getting good pain relief with using a strong opioid with no adverse events, then it's probably better to use a strong analgesic rather than a weak analgesic like NSAID. So that was the conclusion from this trial. And another trial again from India, from a different team in South India, where they compared buprenorphine with diclofenac. Again, a very strong opioid analgesic is compared with a mild analgesic with diclofenac, but small trial, 24 patients randomized in each group. But surprisingly, despite, if you look in the randomized controlled trials in pain and acute pancreatitis in the last 5 years, this is all we have. These are the only two trials we have on pain management and acute pancreatitis, despite the thousands and thousands of patients presenting with acute pancreatitis. It just shows how difficult it is to recruit into pancreatitis clinical trials. So going back to this trial, 24 patients randomized in each group. Again, better pain relief in the buprenorphine group, less need for rescue analgesic in the buprenorphine group compared to diclofenac. But again, the adverse events were very similar between the two groups, and local complications are again very similar. So again, if you have access to a strong opioid, it's better to give a strong opioid to improve pain, and hopefully that will result in better clinical outcomes. But neither of these trials were powered to look at local complications or mortality. So that was the conclusion. Buprenorphine is more effective than diclofenac in pain management, and limitations for small sample size and two analgesics which are not equipotent in analgesic efficacy. So we wrote this short letter after the second trial were published, and most of the randomized trials in pain and acute pancreatitis have several shortcomings in intervention design, sample sizes. Most of these were chosen with a primary endpoint as rescue analgesic, but we also need to think about from a patient perspective using patient-related endpoints such as pain control. And also PPI, there wasn't any PPI involvement in any of these trials, but that's something we need to look at. So the primary outcome measures are directed towards what patients want rather than what the trialists want. So we've just completed the European guidelines on pain management and acute pancreatitis, which have led, and this was around 3 years of work. We had multiple societies in the UK and in Europe who have supported and endorsed these guidelines, or also part of these guidelines, and these should be published in the next 2 to 3 months. They're currently with the journal. And this is the schema we came up with in terms of pain management and acute pancreatitis. You can always start off with NSAIDs, given the good evidence on COX-2 inhibitors and reducing the severity of pancreatitis. And then depending after the pain score, if the pain scores are less than 3, you can start with weak opioids, also consider using laxatives. However, if the pain scores are high, then you have to move on to strong opioids such as buprenorphine or pentagocin. In the UK, we tend to use a lot of Oromorph as a strong opioid. And again, in patients who are at risk of developing respiratory failure, you could consider using epidural analgesic. So the pain management should be based on pain scores and consider using NSAIDs to start with if there are no contraindications. What about antibiotics? Two recent guidelines, the American College of Gastroenterology guidelines on pancreatitis and IAP guidelines on pancreatitis, both recommended antibiotics should be used if there is proven extrapancreatic infection and if there is a strong suspicion of infected pancreatic necrosis. Proven extrapancreatic infection is relatively easy to diagnose, whether it's from blood cultures or from consolidation in the chest or any other site outside the pancreas. But diagnosing pancreatic necrosis related infection is quite difficult. We used to do fine needle aspirations, but there's also a risk of infecting the pancreas with FNAs, and that's not being recommended anymore. And the guidelines also recommend against using empiric antifungals and when the patients have severe pancreatitis. And this is why we need to treat patients with necrotizing pancreatitis, because the mortality risk we see, the late deaths we see, is because of infected pancreatic necrosis. So we skip CT-guided FNAs now to diagnose infection, and we use antibiotics based on clinical suspicion of infection and often with microbiology advice. But clinical suspicion is often is quite variable. If you do a survey of 10 different specialists, the clinical suspicion, often when I go to the wards, overnight someone had SARS from ongoing pancreatitis, and you come in the morning and the patient have already been started on antibiotics. So we need a better modality of confirming infection in acute pancreatitis rather than just relying on clinical suspicion. And that's where the ProCap trial comes in. ProCap trial is a randomized controlled trial done in Manchester by Professor Ajit Sirivardhana, who was the previous president of EHPBA. This was a single center trial where 260 patients were randomized with 130 patients in a procalcitonin guided antibiotic use group, and the other 128 based in antibiotics use based on clinical suspicion rather than a procalcitonin algorithm. And they've clearly shown in the trial, if you use a procalcitonin guided care, you have reduced use of antibiotic use, they have reduced prophylactic use of antibiotics, and you can also reduce costs. But it doesn't result in any improved other clinical outcomes. The mortality is very similar. The risk of hospital-acquired infections is very similar, as well as the hospital stay. It doesn't seem to result in any improved clinical outcomes, but it reduces the inadvertent use of antibiotics. So some limitations. Single center trial. It's again challenging to do multi-center randomized control trials, but you have to commend doing, even though it's a single center trial. It's 250 patients were randomized over a period of 2 to 3 years, which is a huge amount of work for a single team to do. And the trial was completed as well. So that's a big achievement on its own. Other limitation, procalcitonin doesn't differentiate between pancreatic versus extrapancreatic infection, and also cost-benefit analysis and quality of life implications of using a procalcitonin algorithm was not fully explored in the trial. But at least this trial will change our management of going forward, that we should be using a procalcitonin-based algorithm, at least to reduce antibiotic use in patients with the predicted severe pancreatitis or severe pancreatitis. Timing of intervention, we rely a lot on this randomized control trial done by the Dutch, the step-up approach versus open necrosectomy trial, where they've shown with the step-up approach there is significant reduction in mortality. Step-up approach would be starting with a percutaneous drain, followed by endoscopic drain, and then endoscopic necrosectomy, and eventually do a percutaneous necrosectomy if needed. So that would be the step-up approach. And the principle behind the step-up approach is always delay the debridement until you get to 3 to 4 weeks, and then drain it first, and then move up to debridement. So that would be the step-up approach. So that's always been our standard management. We wait up to 4 weeks for everything to wall off before we debride. But what about, is there a group of patients who you could do an upfront endoscopic necrosectomy straight away without having to do a step-up approach? And will that result in any reduced requirements for intervention and morbidity and mortality? This is a trial from America where they randomized 70 patients, where it's a small trial, but still a randomized trial, where 37 patients were randomized to receive upfront necrosectomy. So they came into the hospital, they have potential walled-off necrosis within the second week or third week, and they had an intervention for endoscopic necrosectomy. And then there was 33 patients in the other group where they received a step-up approach. And what they've shown in this trial was with the patients in the upfront necrosectomy, the number of interventions were much lower in the upfront necrosectomy group rather than in the step-up group. But it didn't really result in any improved clinical outcomes. The length of stay and post-pancreatitis complications were very similar. So, but they did suggest early intervention is still could be considered in those patients with encapsulated necrotic collections. Limitations of this trial, only patients amenable to endoscopic treatment were included. There are patients often we see with pancreatitis who may have a collection in the pancreatic bed, but they also have collections in the paracolic gutters going to the retroperitoneum. Often these need percutaneous drainage with a radiological drain, so none of those patients were included. And again, the study was not adequately powered to show a difference in mortality. What about long-term follow-up? This data from the Hungarian pancreatitis study group published earlier this year, where they had patient-level data where they followed 2,600 patients over a period of 12 months, clearly showed post-discharge there is also a significant risk of mortality. The 12-month mortality is 5.5%, and in-hospital mortality is 3.5%. So post-discharge, there is ongoing risk of mortality, and the most common cause of mortality is post-discharge tends to be cancer-related deaths, depending on age. And the second most common cause is cardiac disease and cardiac failure, which is an interesting finding. And this was not something which was previously looked at or explored, but this study clearly shows post-discharge there is ongoing risk of mortality. These patients need followed up for a period of 12 months. And when we looked at the HES data from England, again, we found very similar findings. The in-hospital mortality from the UK HES data over a period of 10 years was around 4.5%, comparable to international mortality rates. But when you look at 1 year, 2 year, 5 year, and 10-year survival rates, the 1 year survival post-discharge is 90%. So almost 10% of patients die at the end of 1 year. And when you get to 10 years, almost 40% of patients die around 10 years. And again, this is different for each age groups. Once you go beyond 80 years, the 10-year mortality is almost 90%. But even the ages between 50 to 59, as you can see here, the mortality risk at 10 years is around 25%. So there is a need for ongoing follow-up for these patients post-discharge. And that means a more healthcare burden as well as economic burden. This is a systematic review we published a couple of years ago where we looked at the quality of randomized controlled trials published so far in acute pancreatitis. All randomized controlled trials published in the last 50 years. We've looked at all of those. And as you can see, the number of trials compared to when we first started in 1975 to 2022 have been exponentially increasing. And quite a few of these trials, at least in the last 4 to 5 years, which explains all the evidence we have seen from the published data in the last few slides. But there's always a concern when so many trials are published. What about the quality of these trials? When we looked at the risk of bias analysis in these trials, there is quite a few number of trials had some concerns or high risk of concerns of various aspects, whether it's bias due to reporting, bias due to outcome measures, randomization, missing data. So I think when you want to put any of these trials into clinical practice, it's really important you look at the clinical trial, look at the data before you put that into clinical practice. And that was the conclusion from the systematic review. Although the number of clinical trials have improved or increased over time, there were significant shortcomings in the methodology of these trials, and there's still need for ongoing clinical trials to improve the evidence base in acute. We've come a long way, but there's still a long way to go, at least in reducing the mortality in the first 1 to 2 weeks in risk modulating the disease. Thank you. Thanks very much. Thank you for listening.
That's great. Thank you so much for this overview of the sort of key trials in different areas of the management of acute pancreatitis. I think that some people may have spotted that Sarv has put in the chat that the chat is closed, but if people have any questions, can they put it in the Q&A tab, which is at the bottom of the screen in the Zoom call, and we'll be reading those as we go along. Can I start off because you mentioned in terms of the risk modulation, obviously the study looking at COX-2 inhibition, which had very sort of striking results. Is this are COX-2 inhibition something that you would then advocate for, or is that something that we need more studies looking at?
I think there is conclusive evidence now from 2 trials, adequately powered trials with a good sample size, showing that COX-2 inhibitors can reduce the inflammatory response, can reduce the SIRS response, which in turn can result in reduction in severity of pancreatitis. So I think that should be something we should be considering, like using procalcitonin for antibiotic use. Similarly, COX-2 inhibitors should be considered, and that means it should be. The challenge with using any of these evidences in the UK, we rely a lot on NICE guidance. And the last NICE guidance was in 2017, and hopefully when we do the next set of NICE guidelines, when they come out, all this evidence should be incorporated. So we clearly have a pathway, a bundle of care for early management, and that should include the use of COX-2 inhibitors.
Yeah, yeah. And so obviously with the NICE, there's always going to be a delay in the guidelines being issued and then furthermore adopted. And in terms of because so I guess that you mentioned a lot of you mentioned about risk modulation, and there's always this, I guess, dichotomy again, the inflammatory versus the enzymatic. Do you have a sense of where the research is going or should go in terms of risk modulation for acute pancreatitis in the early stages?
I think that it's all about dampening the SIRS response, and the reason why patients are so unwell and so sick in the first 2 to 3 days when they get this rampant SIRS response, which often is unabated and just results in multi-organ failure quite quickly within a week, often with respiratory and renal failure. It's about dampening that the inflammatory surge of interleukins and the SIRS response, and that's why we need the anti-inflammatory trials where they can dampen that response, and that's what the RAPID Eye trial is looking by using infliximab to dampen that SIRS response to see if we can prevent progression of predicted severe pancreatitis. But also the challenge is the prediction models are so poor. We'll have to rely on whatever model we have the best at the moment, which should be the BISAP score or the SIRS score. But that's the best we have at the moment, and maybe potentially in the next few years, AI models will give us better prediction models. But I think the challenge is for trials, early phase trials, including the trials looking at dampening the inflammatory response, is identifying the patients at risk of developing severe pancreatitis.
Yeah, yeah. And as you said, the severe acute pancreatitis actually is quite a small cohort, and so actually getting adequately a lot of the trials that you mentioned in terms of the power that's required is you do need, I mean, at a single center, it's just very difficult to achieve those numbers. And from what I can tell in terms of the literature, it's a lot of trials look at, on patients in an intensive care setting to look at modulating the SIRS response. And so obviously the acute pancreatitis gets lost, or the signal from it just gets lost amongst a larger cohort.
Yeah, absolutely. I think if you look at most of those trials, apart from the two trials from China looking at COX-2 inhibitors, the rest of the trials included all comers. That means all patients coming with acute pancreatitis. Those were the only two trials from China where they included patients with predicted severe pancreatitis at randomization. And I guess it must be big centers with access to the patient group to be able to do those trials. But I think that is the biggest challenge because the cohort of patients with severe pancreatitis is only about 10 to 15%.
Yeah.
And in Newcastle, maybe we see one patient a month with severe pancreatitis. And if you want to do a trial here, it's very difficult to do that because you need the patient cohort to be able to recruit into the sample size, whichever you have calculated.
Perfect. Yeah. And can I just a note to encourage people to post their questions in the Q&A, so that we can discuss them in the webinar, or let us know if there's any issues. But on the topic actually of trying to identify patients who, this small subset of patients with acute pancreatitis who will develop a moderately severe or severe acute pancreatitis, what is your practice at the Freeman in terms of identifying those patients early? Do you rely on predictive scores and then use a proactive approach to for early referral to HDU and ITU, or do you rely on things like the news score, etc., and have a more sort of responsive approach to it?
So we use the SIRS score because that's the easiest one to use. And if there is someone with SIRS and then we use the SIRS score is linked with the new score and then it gets escalated to the SHO level or the registrar level, and the patient is unwell, then it gets escalated to the HTU level. You have to also remember there's a lot of pressures on the HTU, but unless the patient needs some form of organ support, the patient doesn't get transferred to HTU. And we don't have the facility of moving every patient with SIRS or predicted severe pancreatitis to move to HTU in the UK in any hospital. So you'll have to rely on early management. That's why having a bundle of care for early management of pancreatitis will make a big difference on the wards.
Yeah, yeah. I see there's the question in the chat about just what we've asked here in terms of the recommendations for risk scoring patients on admission. So you would say that just using the SIR score is the right thing, not the, I guess, Glasgow, etc., or Apache if you're being non-specific.
Yeah, I would recommend using the SIR score or the BISAP score, which is bedside acute pancreatitis score, because these are both simple and pragmatic to use. You don't have to wait for the blood results to come back. A Glasgow score might need a blood gas, an Apache score might need a blood gas. It needs to be pragmatic and bedside usable score, which are we going to develop. And I think that's the benefit of using the SIR score. And we've done a systematic review looking at the pre-test and post-test probability of predicting severe pancreatitis, and SIR score and BISAP score out modeled most of the other scores we use, including Ranson score and Glasgow score. And that's what I would recommend to use in predicting severity.
I guess another question I have for you is about thrombosis and VT in acute pancreatitis. In particular, splanchnic vein thrombosis is something that I've seen a lot in practice, but not necessarily seen a tremendous amount of evidence for. Could you discuss that specific complication of acute pancreatitis?
Yeah, there's no big randomized controlled trials. You're absolutely right. The higher the number of necrosis in acute pancreatitis, the higher risk of developing splanchnic vein thrombosis. And it could be in the SME portal vein or the splenic vein. And we've published some data on this where we have a selective policy of anticoagulation. It's about risk balance of anticoagulating because there is always risk of bleeding with anticoagulation. So we tend to selectively anticoagulate patients with portal vein or SME thrombus, but not anticoagulate patients with splenic vein thrombus. We only anticoagulate splenic vein thrombosis if on serial scans the splenic vein thrombosis is progressing. So if you do a scan today, it's in the distal splenic vein, and then a scan a few days later shows that the splenic vein thrombus is progressing towards the SME portal vein. Only then we would anticoagulate. And we've again shown with that strategy there was no increased risk of complications. But there is no randomized data to say that one way is better than the other. Although we didn't have increased risk of complications with splenic vein thrombosis, we don't know if by anticoagulating them will reduce the risk of left-sided portal hypertension in the future. We don't know that.
Yeah, we don't know that. So I've got a few more questions from the chat. So the first one is is there a role for routine imaging or for serial interval imaging in patients with severe acute pancreatitis? So do you monitor them on a regular basis, I guess, for timing of interventions, etc.?
We don't. I mean, we definitely do one on day 5, day 6 to assess the severity of pancreatitis and extent of necrosis. And then after that, we only do it when there is a need for clinical need. A lot of patients just get away without having to do further scans because there are patients with severe pancreatitis who stay in the hospital for 3 to 4 months and end up getting 20 scans because they get scanned every week. But we only rely on using the scans if it's going to change the patient management, whether undertaking a further endoscopic intervention or if the CRP and white cell count is going up. So it's based on the clinical read rather than doing it every 7 to 10 days. But in my experience, if you have a patient with pancreatitis, you end up doing a scan more or less every week because they become unwell more or less every week with raised CRP.
Yeah, they can get a huge number of scans during a 4 or 6 month admission.
Absolutely. I think we looked in a study where we looked at a number of scans. It made a number of CT scans for patients with severe pancreatitis around 9 during the hospital stay. So they get a huge number of CT scans.
A huge number. And of course, they'll be in hospital for a period of time, but actually full recovery will take, I don't know what you tend to quote, but I normally say sort of however long you're in hospital, at least 3 times that once you're out of hospital. And so there's the long tail of severe acute pancreatitis and a lot of the nutritional needs and the sort of catabolic state that goes after. So interesting what you mentioned about the Hungarian pancreas group looking at the outcomes in the long term. Do you have any specific strategies for nutrition for patients or long-term, I guess, exocrine insufficiency, another issue?
Well, if they have severe pancreatitis, they get routinely followed up after discharge for at least 12 months, because often these patients have gallstones and in the lab chole is done, which often happens 6 to 8 months post-discharge because they're not well enough to have a lab chole on their admission. And interventions wise, they're nutritionally optimized at the time of discharge, unless the dietitian recommends they should go home with enteric feeding. A small number of patients go home with enteric feeding. But the biggest challenge, apart from nutrition, is also rehabilitation, because there is so much sarcopenia and so much muscle loss. These patients need an exercise program when they get discharged, a prehabilitation or a rehabilitation program post-discharge, which unfortunately we don't have in the NHS. Because in a study, we found that about 70% of patients will have ongoing sarcopenia post-discharge at 12 months in severe pancreatitis. So there is a huge amount of ongoing burden post-discharge. Again, potentially that sarcopenia could again be a risk factor for cardiovascular disease. But ideally, an intervention shouldn't finish in the hospital, but they should have ongoing nutritional support as well as physiotherapy support post-discharge. But we currently don't offer that in the NHS because of resource constraints.
Yeah, and post-operative, post admission follow-up and ownership of the patients can be an issue in terms of, I'm aware that here in Edinburgh, we've got a lot of, so ITU will be doing a lot of the follow-up for those elements like the diet, sarcopenia, rehabilitation. But I guess there is the issue of ownership in general with pancreatitis, which is when you've got less of the decompression laparotomy and of the surgical interventions and more endoscopic, then it's the ownership is spread out between several specialties, which means it's more difficult to coordinate.
Yeah, although there's an ownership between several specialities, the patient is often under the surgeons. That's how we've practiced in the UK for many, many years, because it used to be a surgical disease with open necrosectomies. And then, although the management is more predominantly endoscopically now, very little surgeon involvement, we're finding it difficult to pass on these patients to gastroenterologists to look after. So it's still going to be a surgical disease, at least for the foreseeable future. And I think it would be the surgeon's responsibility to have that ownership to be able to then liaise with various subspecialties, so we can either reduce the early mortality or timing of intervention and laparoscopic cholecystectomy post-discharge, ongoing rehabilitation. All of that is still comes under the surgeon's remit, at least at this point of time in the NHS.
And I think I've got one more question from the chat, which is for gallstone pancreatitis and whether ERCP early on in the disease process modulates the disease course.
There's good trials from the Dutch where they've shown early ERCP is only indicated if there is cholangitis. In the absence of cholangitis, ERCP is not warranted, might increase the morbidity. So unless the patient has cholangitis from CBD stones, there is no indication for ERCP for gallstone pancreatitis. I think for gallstone pancreatitis, it's still early management as we do for an acute pancreatitis. And when the patient is well enough for a laparoscopic cholecystectomy, they should have it ideally on the same admission if they have mild pancreatitis or within 2 to 3 weeks of discharge. That's what the NICE guidelines say in mild pancreatitis. In severe pancreatitis, in my experience, it takes up to 6 months before they can get the gallbladder out.
And even then, it can be a whole day journey, can't it, to get those gallbladders out?
Yeah, they are the most difficult gallbladders to do. Because high risk of conversion, high risk of damage to the common bile duct. So yeah, those are not straightforward lab colis, which you can do in a day treatment center. They have to be within the hospital. So you have the facility of converting to an open procedure if you have to.
Yeah, no, not for the combined list. I think it's coming up to 7:45, so I think that's all we have time for. Thank you so much for giving us that presentation, giving us that update on the evidence, and for everyone who joined us. I've been asked to tell you about next week's webinar, which is on the 10th of December, so in a week's time, which will be on the management of Boerhaave syndrome, and that will be with Nick Maynard and shared by Sharif Mahdi. So please do join us for that. And then the week after, on the 17th of December, will be the evidence-based for the manage of HCC, and that will be with Krish Menon and chaired by Cameron Fairfield. So Professor Pandanaboyana, thank you again for coming and giving us that webinar. And I hope that everyone who watched enjoyed it. And thank you very much for the questions that we received. So thanks very much, and have a great week.
Thank you. You too. Thank you, Alex. Have a good evening. Bye-bye.